Welcome back to the physiology of the gastrointestinal tract. Today I will continue lecturing on the gut motility patterns. Uh, in the very first part of these lectures, what I've done is I've divided the topic into two parts. The first part was general gastrointestinal physiology, and the second part was special gastrointestinal physiology. In the first part, uh, we've given a definition for the gastrointestinal tract. We've studied the different structures of the gastrointestinal tract and the different components of these structures. After that, we've talked about the control systems of the gut, intrinsic and extrinsic, and we then talked about the endocrine system of the intrinsic control system of the gut. That concluded the first part of the lectures, and that is GI physiology general, or the general aspects of the physiology of the gastrointestinal tract. Then we moved yesterday toward the special gastrointestinal physiology, and I said that in that section I will be talking about the specific functions of the gastrointestinal tract. If you remember, we have four main functions for the gut: digestion, absorption, secretion, and motility. And yesterday we talked about motility, to be specific. I've given a number of general points. I said that the smooth muscle cells are the main contractile tissue in the gut. There are some places where you have skeletal muscles. Also, I've said that the smooth muscles of the gut are innervated by enteric neurons, which basically contains verrucosities to secrete neurotransmitters along the axon of the enteric neuron. After that, I said that the smooth muscle cells of the gut are connected electrically or ionically by what we called nexuses or gap junctions. These gap junctions between the smooth muscle cells, which are organized, by the way, in a unitary fashion, units. These nexuses or gap junctions allow a relatively free movement of ions and electrical activity between the smooth muscle cells. After that, I mentioned that we have two types of muscle contraction. We have aphasic, which stay for few seconds, and we have a tonic contraction, which lasts for minutes and sometimes hours. After that, we talked about the two mechanisms that will cause the contraction of the smooth muscle cells, and we've mentioned that these mechanisms are electromechanical coupling, and that is by either changing the action potential of the smooth muscle cell membrane, and then after we change that, we increase intracellular calcium. Once we do that, we allow a number of physiological processes that will lead to actin and myosin interacting together to cause the contraction of the smooth muscle cells. And I also mentioned a very important thing, that in order for contraction to take place, we have to have two requirements. This is extremely important. Two requirements. One is an action potential coming from the enteric neuron. The second thing is we have to have a slow wave coming from the ICC or the interstitial cell of Cajal. especially the plateau phase of the slow wave. When these two things meet together, the slow wave, especially the plateau phase, and the action potential, contraction will take place. Now, what I will do is I will talk about the specific motility pattern of each of the gut parts. These are the different parts of the gastrointestinal tract, starting all the way from the oral cavity, then comes the esophagus, then the stomach, and after that, the small and the large intestines. What I will do now is I will talk about each of these parts. I will mention the motility patterns for each of these parts. So we'll start with the oral cavity. In the oral cavity, there are two motility patterns divided into two stages, or done in two stages. The first stage is the oral stage, and the second stage is the pharyngeal stage. The oral stage causes mastication and chewing of the ingested material, and this stage is controlled by the mandibular and trigeminal nerves. The pharyngeal stage is concerned with swallowing the ingested material, and it is controlled by the vagus and the glossopharyngeal nerves. So the oral phase is divided into two stages. Oral stage that does mastication and chewing, and it's controlled by mandibular and trigeminal nerves, and the pharyngeal stage, which is concerned with swallowing this food, and it's controlled by the vagus and the glossopharyngeal nerve. Now, what happened in these stages? In the oral stage, you have mechanical digestion. So what you do is you reduce the size of the ingested material in order to increase the surface area of this material. So the enzymes in the oral cavity, as well as the saliva, will have a better chance in digesting the food. This is important because that's where mixing of all of these materials take place: the saliva, the enzymes, and the reduced sized food particles. So this is the oral stage. Again, this is controlled by the mandibular and the trigeminal nerves. After that comes the pharyngeal phase. The pharyngeal phase has nothing to do with digestion. It's pure motility. It is swallowing, only swallowing. So the oral phase starts the digesting process by reducing the size of the food material and mixing this food materials with saliva and enzymatic uh, molecules, digestion enzymes, lipase, amylase. We'll talk about them when we talk about the secretions of the gut. The pharyngeal stage has nothing to do with digestion. It's pure motility. It is a swallowing. Now, we see failure of this phase or the oral phase, both the oral and the pharyngeal stages, when we have a case that we probably all are familiar with, and that is a stroke. Cerebrovascular injury or stroke will affect the oral phase, both oral stage and pharyngeal stage, both stages of the oral phase, and you will see that the food is being dropped from the side of the mouth. You have paralyses of the cheeks and the mouth muscles and things like that. You probably have seen that saliva will be drooping from the side of the mouth. That's failure of the oral phase, meaning that swallowing is not even complete because of this cerebrovascular injury. Now we finish that oral stage, or oral phase, I should say, and we move to the esophagus. The esophageal phase coincides with relaxation of the stomach. And again, just like the pharyngeal stage of the oral phase, there's no digestion. It's a pure motility phase in the esophagus. Pure motility in the esophagus. What happened is you will have two peristaltic movements, a primary and a secondary, that takes place if the primary fails. The most important thing to remember in the esophageal motility is the fact that there are no slow waves, meaning that there are no ICCs. There is no slow waves, no plateau phase. The control of this motility pattern take place by the vagus nerve. So the vagus is partially responsible for the control motility in the esophagus because it supplies the esophagus, and also myogenic, meaning that the muscle or the cells of the esophagus can generate contractions on their own. Myogenic. There is, depending on the species, there is very little enteric neurons in the esophagus, and in some species there are none, as a matter of fact. Now, what kind of motility patterns we will see in the different parts of the esophagus, and how we can measure these motility patterns, the primary and sometimes the secondary peristaltic movements. Well, we have an upper esophageal sphincter, which is UES, and we have the esophageal body, and we have a lower esophageal sphincter, or LES, which is the cardiac sphincter. The same name for the lower esophageal sphincter is the cardiac sphincter. Some of you might be familiar more with the cardiac sphincter. It's another name for the lower esophageal sphincter. The way we can measure these primary and sometimes secondary peristaltic movements in the esophagus by a measurement through manometer. The measurement will be between 60 and 20 to 40 millimeter mercury. Now, let's see how does that look like. This is a picture that shows recordings, manometry recordings from the esophagus in a human. The most important thing I would like to draw your attention to is the fact that these recordings follow each other, very organized fashion. So the recordings are continuous and they follow each other in a very organized manner. This is a normal esophageal manometry recording. Now, when we have something that looks like this, something that looks like the recording on the right-hand side of the picture, look how the recordings are very unorganized. We call that diffuse esophageal spasms. Diffuse esophageal spasms. This is a disease. This is a disease. When we take a barium study, radiographs, the picture will look like this. We call that a rosary esophagus, or sometimes we call it a shish kebab esophagus. That shows us that the ingested material and the swallowed material from the pharyngeal stage of the oral phase accumulate in the esophagus, and it's unable to move to the stomach, which creates a number of problems: difficulty swallowing, regurgitation of food, vomiting, pain, etc. So this is one of the cases that we need to understand and remember: diffuse esophageal spasms. Another case is heartburn, gastric esophageal reflux disease, meaning that acidic contents come from the stomach and reach the esophagus. This is GERD, gastric or gastroesophageal reflux disease. This causes heartburn, and some of you might have experienced it. Another problem in the esophagus is diaphragmatic hernia. Diaphragmatic hernia. Hiatal hernia. The same thing here. you have stomach contents that arrive from the stomach to the esophagus, causing very severe pain, difficulty breathing, heartburn, and other signs as well. Again, we're continuing on the different problems that happen with the esophagus. We have seen this case, esophageal achalasia, that is due to a stricture formation, stenosis in the esophagus at the level of the cardiac sphincter, which again leads to dilation of the esophagus and difficulty of the food to move in the ab-or-rad direction, meaning toward the stomach. Instead, the food is regurgitated. It goes back to the oral cavity. And this is associated also with pain. So far we've talked about two structures of the gastrointestinal tract, and that is the oral cavity and the esophagus. We said that the oral cavity has two motility patterns, an oral stage and a pharyngeal stage. One does digestion and the other does only motility or swallowing. We come to the esophagus and we have one major motility pattern, and that's a primary peristaltic movement. Sometimes, if it fails, we will have a secondary peristaltic movement. However, we don't have any ICCs, no slow waves in the esophagus. And we've talked that failure of the oral phase occur in cases of stroke or cerebrovascular injuries. And we said that in the esophagus we have a number of problems. One of them is diffuse esophageal spasms. Another is heartburn and GERD, or gastroesophageal reflux disease. We have diaphragmatic hernia or hiatal hernia, and then we have esophageal achalasia. Now we will move to the stomach. The stomach is the third part of the gastrointestinal tract that we will cover its motility patterns. So how does the stomach look from an anatomical standpoint? The right hand side picture shows the functional regions of the stomach, which I will be talking about now. And the left-hand side picture shows the anatomical parts, fundus, body, and antrum. And then you will have the pyloric sphincter. So, what type of motility patterns do we have in the stomach? We have, of course, contraction, and we have relaxation. Two motility patterns, contraction, and relaxation. In order for us to understand these motility patterns, we have to understand the different regions in the stomach, the reservoir and the antral pump. The reservoir is tonic contraction, which occurs for a longer period of time, versus the antral pump is a phasic contraction, which means that it happens in seconds. It happens in seconds. It takes place in seconds. So reservoir takes pretty long periods of times, minutes to hours, and antral pump takes seconds. Both of these are contraction motility patterns. So these are the motility patterns in the stomach. We have 2 contraction motility patterns, and we have 1 relaxation. The contractions are reservoir and antral pump, and the relaxation is gastric emptying, whereby the digested material in the stomach is moved to the upper part of the small intestine, or the duodenum. I mentioned earlier that the reservoir has a tonic type of contraction, whereas the antral pump has a phasic type. How is this important or relevant physiologically? It's pretty easy. When the food enters the stomach, the size of that food is still large, which means that it will be difficult for that type of food to pass through the pyloric sphincter to the duodenum. Therefore, the stomach provides this type of contraction to keep moving the large particles of food continuously for minutes and hours to break it to a pretty small size. So that small size digested food will go to the antral pump, which is the second contraction in the stomach, and it happens in seconds to move the ingested material to the upper duodenum. And please see the difference between the two. The reservoir is continuous because the stomach needs to continuously move the food around so it can break it to a very small size. However, the antral pump is a single contraction, which means that anything that's within a reasonable size, and I will be talking about this reasonable size pretty shortly when I talk about gastric emptying, this reasonable size in one single contraction will move from the stomach to the upper duodenum via the antral pump contraction of the stomach. So two contractions, one is continuous and lasts for minutes and hours, and one lasts for seconds, and it's a single contraction. And both of these contractions are controlled or under the control of both vagus and ICCs or slow waves. Both vagus and slow waves. This diagram shows what I just talked about. So the reservoir continues for hour, sometimes 2, sometimes 3. Continues until it reaches the antrum. The antral pump, so the first slide is reservoir. It works to break the food to a very small size, particles. After that, you have to move it to the antral pump, the second part or the middle picture. In this antral pump, it happens only once and takes pretty short period of time, few seconds, and it's under vagal control, the middle one. In the third picture, you will see that the pyloric sphincter is under also the enteric nervous system control. The enteric nervous system control. When the antral pump contracts, the stomach empties. The stomach empties its contents to the upper small intestines. What happened in each of these motility patterns? So in the reservoir, you have 3 types of accommodations: receptive, adaptive, and feedback, which means that the stomach receives the food from the esophagus and sense that the size, the volume of this food, of course, and fluids, any ingested material, through mechanoreceptors. And then it starts adapting to whatever more food we're eating. Whatever more food, the stomach stretch receptors sense that we're eating more and more and more and more, until a feedback mechanism comes from the intestine, says to the stomach, okay, well, now I'm empty. I need some more food from you guys, from the stomach. And so a feedback mechanism go from the intestine to the stomach, telling the stomach, okay, well, now it's your turn to empty. I need food. You empty what you've digested into the upper duodenum. This is basically how these types of accommodations take place. You have first the reservoir, the tonic contraction, continuous and lasts for minutes and hours. It breaks the food to a very, very small size, decrease the volume, and then this food goes to the antral pump. The antral pump happens for very short period of time, seconds, and it empties the contents, the small contents, into the upper part of the duodenum through a process. Now, after this contraction takes place, that's the antral pump. What happens is we have to have gastric emptying, so the stomach empties. Okay. Gastric emptying is the relaxation motility pattern of the stomach. The relaxation motility pattern of the stomach. And what happened is that you cannot eat and continue eating for an unlimited period of time. It's impossible. So gastric emptying is a protective mechanism. Otherwise, you're going to explode. The stomach is going to rupture, and that's pretty bad. That's death. That's peritonitis, and that's death. So it is a protective mechanism. And what happens is that any food particles that's less than 1 millimeter cubic in size, they will pass through the pyloric sphincter to the upper duodenum. And anything that's more than that, it will not pass. The gastric emptying takes about 15 minutes to 8 hours, depending on the species. Not only depending on the species, but also we will be talking about momentarily, depends also on the type of food. You don't expect liquid food to be staying in the stomach for a longer period of times compared to a piece of steak. So there's a huge difference there. The amount of calories also plays a very important role in this gastric emptying. It has been shown that complete emptying of the stomach occur between 8 to 12 hours after a meal. So 8 to 12 hours is pretty much guaranteed that everything that you have consumed during that meal, the stomach will be completely emptied. And gastric emptying is controlled by the enteric nervous system, the ENS, as well as a hormonal control. And here also cholecystokinin, one of the gut hormones that we've talked about earlier, plays a major role in basically relaxing the pyloric sphincter and letting the food come through the antral pump from the stomach to the upper duodenum by the relaxation motility pattern of the stomach or gastric emptying. Gastric emptying, as I mentioned earlier, is a protective mechanism, and it's a selective mechanism. We call that the sieving effect or the sieving action. How is it selective? Liquids enter the duodenum before solid food. Isotonic solutions gets into the duodenum before hypertonic solutions or hypotonic solutions. Hypocaloric food enters the duodenum before hypercaloric food. Very important to remember these things. Liquid, isotonic, and hypocaloric. 3 different types of foods. In addition, protein enters the duodenum before carbohydrates, and carbohydrates enter the duodenum before fat. So protein gets into the duodenum first, then carbohydrates, then fat. This is how gastric emptying is selective in its action. It is pretty selective. Liquid before solid, isotonic before hypo or hypertonic solutions, and hypocaloric is before hypercaloric solutions. Protein before carbohydrates, and that is also before fats. What I just talked about is illustrated in this graph. On the x-axis, on the bottom of the screen, you will see the time of after a meal in minutes, and on the y-axis, to the left-hand side of the graph, you will see the meal remaining in the stomach. Now, we will see that after eating a liquid meal, that's the very first line, which is at the bottom of the graph, you will see that the liquid meal emptied immediately faster than the solid food and the semi-solid food, which are taking longer period of time compared to the liquid meal. Almost after 20 minutes, you will see that most, or maybe 40 minutes, you will see most of the liquid meal is gone, versus 60 minutes and 80 minutes for the semi-solid meal, and is still there. And for the solid meal, 80 minutes and still about 50% of the meal is still in the stomach. So that shows you how selective this gastric emptying is happening. Now, talking about gastric disorders, we've mentioned gastritis in the very first lecture that I talked about GI physiology, also vomiting. Rate of gastric emptying is a problem sometimes, can be delayed. Hyperacidity related to food and cancers, gastrinomas. We've talked about the Ellison-Zollinger syndromes and things like that. The ulcers, especially in racehorses, dumping syndrome, which is a complication of Roux-en-Y gastric bypass and sleeve gastrectomy, the two surgeries that are used for the treatment of obesity. These are some of the problems that happen in the stomach. You've seen this endoscopic picture before. This is a canine gastritis case. The upper arrow points at the normal tissue, whereas the lower arrow points at the inflamed tissue. This is one of the important cases in the stomach that we need to pay close attention to in diagnosing and the treatment of this case. One of the problems in the stomach is vomiting. If we have, and these are important points to remember, if you have vomiting for a short period of time and it's moderate in strength, then you will have metabolic acidosis. The pH becomes less than 7.4. You will have also associated with that hyperchloremic acidosis. So the chloride level is high in the blood. The body holds the chloride due to the loss of the bicarbonate, sodium bicarbs, that basically neutralize it. We lose a lot of it. That's why you have metabolic acidosis. However, when you have severe vomiting, it's an opposite. You have metabolic alkalosis instead. So the pH is more than 7.4. Why? because we have loss of gastric acid. So in severe vomiting, the acid is being lost from the stomach. That's why the blood become alkaline. Sometimes you will have slow gastric emptying. The stomach is not emptying its content in a timely manner. And that happens in gastric ulcers, vagal injury, infections, hypothyroidism. All of these will cause slowing of gastric emptying. However, in cases of duodenal ulcers, you will have acceleration of gastric emptying. So I want you to differentiate between gastric ulcer and duodenal ulcer. In gastric ulcer, you have slowing of gastric emptying. However, in duodenal ulcers, you have acceleration of gastric emptying. This is very important to remember. You've seen these two endoscopic pictures before. On the left-hand side, it's a normal equine stomach versus on the right-hand side picture, you have a stomach with ulcers. Another problem with the stomach this model, we've seen it before, and we learned how the enterochromaffin-like cell, which secretes histamine, can be activated by either gastrin or acetylcholine, or which is coming from the parasympathetic innervation or the vagus nerve, to be very specific. And when we stimulate this this cell, it secretes histamine, and histamine binds to the H2 receptor on the parietal cell to increase acid secretion in the stomach, or gastrin can bind also to the parietal cell and also increase acid secretion, and also the vagus nerve can activate the parietal cell and also can increase acid secretion. So the way we will decrease acid secretion is by blocking these two receptors. Either we're blocking the histamine 2 receptor on the parietal cell, and we by that we will not allow histamine to bind to the parietal cell, and as a result, gastric acid secretion will not be secreted, or it's not going to be increased. Also, we can prevent gastrin from binding to the parietal cell, and with that, we will see a reduction in acid secretion. Gastrin shares the CCK2 receptor. So if we have a CCK2 receptor antagonist that we can give to the animal or to the human, it will block the gastrin receptors on the parietal cells, and as a result, acid secretion will be diminished. The same thing with blocking the histamine 2 receptor with medications like cimetidine, ranitidine. All of this can be utilized medically to reduce gastric acid secretion. A surgical treatment for gastric ulcers is by vagotomy, selective branch vagotomy. We've talked about it before, and we utilize that sometimes if we are not able to control gastric acid secretion via the medical means, meaning blocking the histamine 2 receptor or blocking the CCK2 receptor. We can cut a branch of the vagus, and we can also cut part or all of the antrum. We call that antrectomy. The antrum is part of the stomach, and that's where the parietal cells are located, and that's where they secrete the acid. So when we cut the antrum, that is also eliminating the source of parietal cells in the stomach, which will reduce gastric acid secretion. Another thing is pyloroplasty. Pyloroplasty also increases the diameter of the pylorus, which means that the contents go to the intestine before they stimulate secreting more and more acid into the stomach. This is basically a picture of the antrectomy, the purple side of the stomach that can be removed surgically, as shown on the picture on the right hand side, Roth 1 technique. And also we can do a truncal vagotomy, selective branch vagotomy. All of this can be utilized to decrease gastric acid secretion. In addition to that, we can do pyloroplasty, increase the size of the pylorus, doing 2 techniques, the Haneke-Michaelis pyloroplasty and the Finney pyloroplasty. Each of these techniques basically increases the size of the pyloric sphincter, which basically allows food to go into the stomach without stimulation of gastric acid secretion. The last gastric disorder is the dumping syndrome, which is a complication following Roux-en-Y gastric bypass and vertical sleeve gastrectomy, VSG. Both treatments are utilized for the treatment of obesity, and these surgeries can have a complication following the surgery, and that is a dumping syndrome. Food starts to be dumped into the duodenum, and the acidity is going to be high because the food is not well digested. And then the treatment for this case is basically a medical treatment. So far I've talked about the motility patterns in the mouth or the oral cavity, in the esophagus, and in the stomach. The oral cavity has two stages, oral and pharyngeal. Oral reduces the size of food particle and mixes it with the saliva and the enzymatic secretions for further digestion. The pharyngeal stage is only motility. It has nothing to do with digestion. Just like the next stage, which is the esophageal phase, but the esophagus does not have any ICCs or slow waves. And then I've talked about the stomach motility patterns, and we have a contraction motility pattern, which consists of reservoir and antral pump, and a relaxation motility pattern, which consists of gastric emptying. In the next lecture, I will be talking about the motility patterns of the intestines.